welcoming Dr. AZADEH Patel, the second speaker of the day, and all the experts. I'll request Dr. Megha to introduce Dr. AZADEH, and I'll just add on that she was with me in the Spain where she was doing the fellowship, IVF fellowship in the Spain, and I joined her for a few weeks. But that memory was so vivid and so good that I really wanted to invite her for a lecture, and I really wanted that she should share her knowledge. She's a young IVF specialist and really upcoming ones. So Dr. Megha, please be forward and welcome them. Welcome, Dr. AZADEH. We can't see you.
Welcome, Dr. AZADEH. No, she's visible. She's visible. Welcome, Dr. AZADEH Patel. She is consultant ART Fertility Clinics, Ahmedabad. Just pardon me for my voice today. She is gold medalist in her field, and she has vast 10 years of experience in gynecology and 7 years in field of reproductive medicine. She has done a fellowship from Madrid, Spain, and diploma in gynecological endoscopic surgery from France. She has many articles in various journals, chapters in textbooks, and posters in papers in various conferences to her name. I think there are so many that I cannot list them here. So welcome, Dr. AZADEH. She would speak on recent advances in poor responders. Over to you, Dr. AZADEH.
Thank you so much. Thank you, DGF Infertility Committee, and Ma'am SHARDA Ma'am. I wish you a very good evening. And thank you for this opportunity. And Dr. Seema, thank you for the recommendation. Yes, we were together for a month or so at Spain, and yes, there were wonderful memories. So with this, I'll just share my screen. So with the poor responder, as rightly said by sir and ma'am, there needs to be some problem, maybe in utero, probably. We still don't know. There's a lot of things that we need to research and know about what really is working for these women, so that we at least try to find it a little early. At least we diagnose it early, then at least we will be able to help these women and counsel them that what would be their appropriate age for their fertility. So I'll take it forward that as, I had prepared the slides, but yes, as we all know that the optimum number of the eggs are at the time of birth, and then it gradually reduces, and then there is an age between 31 to 37 where the fertility will go declining. And how did this concept of poor ovarian reserve come into play is because of most of the IVF center. This was first most of the IVF center, because of the ovum pickup that they did, found that most of the cycles there was increase in the incidence of lesser number of the eggs which were retrieved, less than 5, less than 6, which were retrieved, and that was a big number. So the overall the problem statement and the incidence of poor ovarian reserve is around 9 to 24% in overall infertile group, and that is increasing day by day. This is only an estimation for the last decade, because still many gynecologists, they fail to diagnose this poor ovarian reserve. And the IVF centers have reported almost 61% of the IVF clinics, they have reported an increase in the incidence of POR over the last decade. And as ma'am just said, they are the most challenging group of patients. Also, this, as I said, there was one of the publication which was between 2009 to 2015, where the almost 60% of the ovum pickup with the IVF clinics had eggs number which was less than 9, and 30% of the patient had oocyte number less than 4. So that is how this poor ovarian reserve came into picture. Otherwise, before that, it was all unexplained infertility, that you are ovulating well and things are fine with you. Then we had a study done by Dr. Banker, which came in 2014, where he compared the Caucasian group versus Indian women and found that the Indian women have an ethnic, obviously there is an ethnic difference, and Indian women, they have lesser ovarian reserve, and the ovarian aging is 6 years faster compared to the Western counterpart. Also, I had also done a study when I was in Spain, and this was a study of more than 5,500 cycles, where we compared the cycles from the Caucasian group versus the Indian population, and I had compared the IVF outcome as well. So what we had found, and this was published in an international journal, Gynecology Endocrinology, in the year 2016, where we found that, of course, the age is younger for the Indian women compared to the Caucasian group, which is 6-7 years of a difference. But in terms of outcome, even being younger, the IVF outcome was better in the Caucasian group, though they were elderly women, in terms of the number of the embryo, number of the eggs, and the pregnancy rates. So there was a very recent, I've taken all recent things, and there is a recent publication in 2018 by Alberto, where he has studied that how many total number of eggs are required to produce one euploid or a normal blastocyst. So with a younger age, less than 35, approximately 4 to 5 eggs are required to produce one normal blastocyst. But as the age advances, this number is from 36-37 years, where it is 5 eggs, 38 years and above, it is 7 to 8 eggs. And then later, over 40-42 years, the number increases to 10 to 20. So this is very, very challenging, because as the age advances, the reserve is also less. So it is difficult for these patients to find a normal euploid embryo, which will give them a pregnancy. So what are the reasons for the poor ovarian reserve? First, we know that is age. Patients with the low, high FSH, low AMH, low antral follicle count, the ones who had had a previous response which was poor, if we have any document, or even a previous ovarian surgery for endometriosis or PCO drilling, if it was done, if there were any genetic defects, autoimmune disorders, single ovary, chemotherapy, radiotherapy, smoking, polymorphism of the receptors of FSH and LH is something that is new and studied recently. And the newer risk factors which have been added, first is the diabetes mellitus type 1, because that is an autoimmune disease. So autoimmune thing is also one thing that works for premature ovarian failure, because there have been cases where autoimmune thyroiditis has been linked with POF2. Also, another iatrogenic problem with the uterine artery embolization that compromises the ovarian supply sometimes, and that can also reduce the function. Also, post-salpingectomy after an ectopic pregnancy, especially if the distal part of the tube, which is near to the ovary, is removed, that might also compromise the ovarian supply. So why are we worried about this poor response? Because what we see once the eggs are out in IVF, what we see is that the egg quality is poor, their fertilization is impaired, their embryo quality is bad, they have lower pregnancy rates and higher cancellation rate. Also, it adds up an emotional stress and a financial burden for the patient. So how do we define this POR? There were multiple things that came, whether we define it by the number of the follicles or eggs or estrogen levels, AMH, age, what, but nothing, we don't have a consensus over a definition yet. So there is something which is new for the definition is that we already, all of us know that in 2011, a Bologna criteria was given by the ESHRE, and what that criteria defined was the 3 parameters, which were age more than or equal to 40, or previous cycle, if IVF cycle was done, and then in that cycle less than 3 eggs were retrieved, and the third last thing is an abnormal reserve, ovarian reserve test. So if then antral follicle count is less than 7 or an AMH is less than 1.1, then these 3 were the criteria which were taken into consideration, and either any two criteria out of these 3, if present, then that was defined as a poor reserve. But this did not take into account the poor responders are not a homogeneous group of population, and age cannot be defined. Age more than or equal to 40 and with an AMH 1.1 might be normal, and antral follicle count less than 7 might be the case for an 40-year-old women. So this was very highly criticized, but it still plays some role in predictive value in when if the patient fulfilling the Bologna criteria as a poor responder is taken for an IVF cycle, again the second cycle, then probably it will help in predicting the negative outcome for the second and the third cycle. So it still has some value there. Now, there are, in terms of definition, we have 2 more definitions, that is 2 new definitions. One is follicle output rate. which means the total antral follicles to the pre-ovulatory follicles. So if we have total stimulable follicles, which are the AFC, and out of which how many have turned into pre-ovulatory follicles in an IVF cycle on the day of trigger. So that is FOT. And this reflects the dynamic nature of the follicular growth, and this is exclusively in response to gonadotropin. The second definition is follicle oocyte index, that is FOI, where the total number of the follicles, the antral follicle count to the total number of the eggs retrieved. This is counted. So if you have 10 and 4 eggs are retrieved out of the total these antral follicles, then it is a very poor or a low FOI. So a FOI less than 50 is bad, and more than 50 is a normal or an acceptable FOI. So what are the reasons? In case of hyporesponse, this we term it as hyporesponse, where the FOI index is low. In that, either the dose of the gonadotropin selected was low, and if there can be genetic or the environmental factor, or can be asynchronous follicular development, where we as an IVF practitioner do struggle a lot, and if there can be a technical issues involving trigger or final oocyte maturation, that would have played a role. And empty follicle syndrome, I am sure it's a nightmare for any IVF practitioner, but that is a reality at times. So there is another thing that was proposed, which is the Posadian stratification for the low prognosis patient. That is Posadian classification, which is patient-oriented strategies encompassing individualized oocyte number. So what they did was they took into account not only the age, but also the biomarker and the functional marker, which are AMH and AFC, and subdivided these class of patients that are poor responder. Also, they gave two more definitions to this poor responder in IVF. One is the suboptimal response, where the oocyte retrieved number are less than 9, anything between 4 to 9 at any given age, with a significantly lower chance of having a live birth compared to those who are normal responders. And the second is a hyporesponse, where the higher dose of gonadotropins were required and the stimulation duration was longer. In this case, we term it as hyporesponse. So these two were included in their definition. So, but they have divided this women into 4 categories. Category 1 is less than 35 years of age, that are younger women. On the left side of the category, most of us would have seen that. On the left side, it is younger age, that is less than 35 years of age, where we expect the euploidy rate in the blastocyst to be higher. Right side is more than 35 years of age, where we expect aneuploidy rate to be higher. Now, the above row, that is 1 and the one, first and the second group, has the ovarian reserve test, which are normal. The age is different. One is less than 35, this is more than 35. But the ovarian reserve test are good, where you will not expect a poor responder, but still they are poor responder because they have given suboptimal response. Whereas the second row, which is category 3 and category 4, are in expected poor responders, where they would have poor ovarian biomarkers. That is, AFC would be less than 5 with an AMH less than 1.2. Category 3 groups are the ones which needs a special attention, because they are young women with the poor reserve tests. There are multiple strategies to...
Excuse me, Azadi, we can't see the slides. I think Megha has stopped sharing the slides. Megha, please check.
Trying for the full screen part. I was just trying for it.
Can you please share? To help these patients out, either that is before any treatment or during the IVF stimulation, or after, once we have the eggs out, then what to be done in the lab. So there's various studies which are going on, but what can be, the first foremost treatment that I can suggest for poor responders, because time to pregnancy is extremely crucial for these patients, and medical management wasting their months would probably not be a good idea, where you have another strategies. And even these patients face a lot of difficulties and a challenge even with the IVF thing. So I have not gone into details about this because I thought probably putting up IVF thing would be not right. But just to give a little summary about it, that which protocol to be preferred, agonist or antagonist. But nowadays, worldwide, antagonist protocol
I'm
is
able to
widely.
share, Dr. Azadi. You can see it now.
Yes. Okay. Yes. Thank you. Please. Yeah. So antagonist protocol is the one which is preferred nowadays. But yes, the practitioners who like to stimulate these patients with agonist or microflare protocol, that is also right. Yes, but this slide. Yes. So there is no consensus, but more or less there was a recent Cochrane review which favored the antagonist protocol, which was around 2016-2017. Then what dose of the FSH to be selected, whether it is 300 or whether it is 450, that dose, about 300 dose, nothing makes a difference. Even there is no difference in terms of outcome between 450 to 600. And there is obvious difference between 150 to 300. So that is what in terms of dosage. Clomiphene we usually try to add at times because that gives a good flare effect for recruitment of the follicle. What I like is addition of the growth hormone. I usually try to add growth hormone to these stimulation. So the next slide, I'm not taken much of the IVF part, but this is something that I want to highlight is the dual stimulation, where the conventional protocol for IVF is done in the follicular phase, and that stimulation is triggered with an agonist trigger, and the pickup is done. Then there is a free period for 2 to 4 days, and then again the luteal phase stimulation is started. This concept is developed because there are usually 2 follicular waves for most of the women. One is the follicular wave and one is the luteal wave for the follicular recruitment. 30% of the women will have ovulatory follicular recruitment too. So this concept developed out of that let us take maximum benefit from one cycle, and it is widely done for the fertility preservation. But this is an upcoming thing, and this is still most of the practitioners now have started doing dual stimulation for the poor responder. That increases chances of more number of eggs from a single cycle. Cryo accumulation of the oocyte is one of the very good strategy where you collect eggs from 2-3 cycles and then go ahead with the fertilization. So that is something I even like to do. But these patients, obviously, oocyte vitrification is something that if they are at threat, then they should be considering. This polytropin alpha, corifolitropin alpha is still not available in India, but there was this trial where they compared between corifolitropin alpha and the recombinant FSH, and they found no statistical difference. So they compared that it is equally good, and it has a advantage that it has to be injected only 1 compared to the 7 daily dose. So this was one of the multicentral RCT which was done, and they said that they had a very low cancellation rate when used. So again, what ma'am was saying that most of the studies revolving around this are funded by pharma, so it is very, very difficult to predict and start using it. But still in India, it is not available. What Dr. Seema wanted me to stress upon was the adjuvant treatments, which is a pre-treatment, what to be done before the IVF stimulation. First is, as we know, what we can do is androgen or androgen modulating drugs. Either during stimulation, we can give growth hormone. We can either plan a pre-treatment and suppress the ovaries to pick up more number of eggs. And the last is PRP and antioxidants. So I'll start taking one by one. The first is the androgen supplementation. As we all know, androgen is the substrate for forming the estrogen. The androgen will get converted into estrogen under influence of FSH, which is 2-cell to gonadotropin theory. But how do this androgen is received by the granulosa cell is from the theca cells. Now, LH will act on the theca cell on the LH receptor and convert the cholesterol into androgen. This androgen will be transported to the granulosa cell, and under the effect of FSH, this will be converted into estrogen. So, if the estrogen in the follicle is less, either because of the androgen which is not available, then obviously the follicle will fail to develop. So there are strategies which were thought of. First is stimulating the theca cell by the LH or the recombinant LH. Second is giving directly the testosterone or DHEA, or then blocking the conversion from androgen to estrogen. So these were the proposed strategy. But why is it so important, LH? LH, because it acts as the follicular level and it is very, very dose dependent. It acts in a dose dependent manner to increase the androgens, and then they aromatize to estrogen. This action of the LH at the granulosa cells, it enhances the responsiveness to the FSH. It also increases the responsiveness to the follicle stimulating hormone, and it has a direct positive effect on the final oocyte maturation, and that improves the oocyte competence and endometrial receptivity. But what happens with the age? With the increased advanced age, the functional receptors are reduced. The LH receptors get reduced. Also, the androgen production would be limited. Then the bioactive LH is also less. And there is also reduced intra-ovarian paracrine activity. So, understanding all of this, recombinant LH or the importance of LH in poor responder or higher age women, we usually add LH always in IVF stimulation when we are stimulating little higher age women, and that is a preference. The reason is this. So this drug, the recombinant LH, which is Pergoveris, came into practice, and it is now available in India by Merck, but still now it was not available. They did studies and they found that there is no statistical difference when recombinant LH was used compared to the other LH hormone, and especially they found a beneficial effect of using recombinant LH in poor responder. And yes, it stands true because it is widely studied, but it is very, very expensive, and it's a limited, it's a questionable thing whether to give this cost to the patient or not. There was a PERSIST trial which was done on this Pergoveris, where the recombinant LH was started at the first, compared to that on the 6th day of the stimulation, and they found that if given from initial stimulation day, it had a better outcome in terms of pregnancy. There are various ways to supplement LH. Either you give highly purified HMG, which is Menopure, or there are Indian companies also. They have come with HPHMG, and they have very good response. And also HCG was studied because it has a similarity with the LH. But I don't prefer giving HCG. I always prefer HPHMG for these patients. The second is DHEA. As we know, it created a lot of hype and wonder, and it is up because the concept being because it is a pro-hormone in ovarian follicular steroidogenesis, and that when we supplement DHEA, it increases the serum insulin-like growth factor 1 concentration, and this in turn, it increases the growing pre-antral and the small antral follicle. It is also believed that it would improve the oocyte quality and promote the DNA repair. So the dose is 75 to 80 milligram over 6 to 8 weeks in 3 divided doses. So I think most of us are using DHEA. I don't use it because I don't believe in allowing patient to wait for 2-3 cycles when she's already at threat. So this is the mechanism I just discussed. There were multiple papers initially about the sterilization, embryo quality, pregnancy rates, decreased miscarriage rates. So there were multiple papers in favor of DHEA which started coming. But gradually there were multiple papers which also started coming which were DHEA and very well studied papers. So still we require RCTs, proper well-designed RCT to really verify whether there is a beneficial effect or not. The transdermal testosterone, this is something that probably might work for these patients because it is giving androgens directly. But the dose again is a question mark, whether to use 5.5 milligram per day or 10 milligram, 12.5 milligram, and the duration, either 2 months, 1 month, or 10 days before stimulation, everything is question mark and needs to be studied. But I think most of the practitioners across the globe, they have started using testosterone gel and they do see a beneficial effect. this a transport trial which was done in 2017 where they have used 5.5 milligram of testosterone and per day, and this is almost 2 months before the control ovarian stimulation. So we will be awaiting their results, and this was one of the RCT which was published in 2019, 2 years back, which showed that testosterone therapy probably seems to be promising. Then the next strategy is addition of the aromatase inhibitors, and letrozole was studied, but it's not much into practice, where there were certain papers which showed that probably the number of the egg, number of oocytes were little improved, and the dose reduction for FSH was there. So it has some evidence there. What I like to use is the growth hormone, because that stimulates the estrogen production, and it stimulates via the insulin-like growth factor receptors, which are present on the oocyte as well as the granulosa cells. And also the growth hormone is believed to enhance the nuclear and the cytoplasmic maturation and repair the DNA. And what I have been using for quite a long time, and I feel it does its work really well. So this was one of the recent RCT and meta-analysis of the RCT, where they have proven that growth hormone has a role to play while stimulating these patients. And everything was in favor for growth hormone, and this is something which has been well established now. Also, there is always a confusion and dilemma for stimulating these patients, because most of them, they end up with a asynchronous response. Then how to develop that synchrony? So the concept of luteal phase manipulation was there, and it has been proposed. Well, there are two things majorly used for that manipulation. One is estrogen, where we start estrogen 4 milligram from the previous cycle 21 days for 10 days and stop with the menses and start with the stimulation, giving it a washout period. Second is giving antagonists. Either we give 3 antagonists for 3 days before the stimulation, or give a loading dose of antagonists. But I prefer estrogen. But at times goes ahead with the excessive suppression, and then the later the stimulation would be little longer, but a synchronous development. So, but still use of antagonists for this priming is still the programming is still needs a lot of research. Then I'll just go a little quickly, and in poor responder estrogen, luteal estrogen priming has been well studied in the meta-analysis, and it improves the chances, decreases the chances of cycle cancellation and improves the chances of pregnancy. That is what that meta-analysis said. Also, there was a study which compared antagonists along with estrogen for the pre-treatment, but it did not show any benefit. There has been one of the proposal that you give estrogen priming and then give antagonist and then start with the stimulation after on the 7th or the 8th day of the cycle, but still needs to be studied. Also, the role of OC pills. OC pills, why do we use OC pills is in an agonist cycle so that the cyst should not form. For antagonist cycle, it has been condemned that it increases the duration of the stimulation, increases the dose, and resulted in small but significant reduction in the pregnancy. So, there was a meta-analysis where it proved that probably in an antagonist cycle, pre-treatment OC pill should not be done unless and until there needs a programming, but not for pre-treatment and for synchronous development. There is one more Fisher protocol where they use norethistérone for 10 days, the previous cycle 10 days, and that had to be stopped. And with the menses, the stimulation was started. This was little low dose, but it still needs to be well studied. Then the role of antagonist, as most of us are using antagonists with the concept of the reactive oxygen species that do the damage to the oocyte, the granulosa cells, and the mitochondrial DNA. To prevent this, we have to give antagonist. And as the previous talk, there are various things in the market. Most of the things are given by the pharma company and information, and we start using it. But what does the evidence say? The evidence right now, as of now, only concentrates on the CoQ10, which has some evidence of improvement. But yes, we are using and we do observe a little difference too. So CoQ10 is believed to improve the mitochondrial oxidative stress. The next concept, which is ovarian rejuvenation, is still under research purpose, and that the intention is to reawaken the egg maturation and the development from the ovary. So this theory, the theory behind this treatment is that it allows the natural healing process of the body with the use of the platelets, because these platelets, as we know, they will release a lot of growth factors, and the follicles which are arrested at the pre-antral stage, they are governed by the intra-ovarian growth factors, and hence while giving the platelets, that all the growth factors are released, and there would be neovascularization as well as the tissue regeneration that happens. So the procedure is harvest the blood, separate the platelets from the rest of the blood, activate the platelets, and then inject. So that is what is done. So the preparation of PRP, it is an office procedure, and it is very easily done. Mostly autologous PRP is used, and it is centrifuged twice, first to remove the red blood cells and the second to remove the poor platelet poor plasma. And this increases the growth factors by 5 to 10 times. There was a study where the initial report was a report of 3 live births in a woman with the poor ovarian reserve following this PRP, and then there were multiple papers showing benefits, but still it is very, very experimental, and we don't know if it does any harm. So these are the factors that platelets do release, that is vascular endothelial growth factor, platelet-derived growth factors, and TGF-beta, epidermal growth factor, and fibroblasts. So all of this would go ahead with reparation, and this is the procedure of preparing PRP, which I just mentioned. And what are the indications? Indications for PRP either would be the menopausal, perimenopausal women, or POF women, or women less than 35 years of age with a lower egg reserve or an ovarian dysfunction. So it is still experimental, needs to be studied, and it is not routinely done. Now, there was something which was new, was a recommendation by ASHRAE for poor responders. This was in 2019, where they said that agonists and antagonists are equally recommended, and clomiphene along with IVF stimulation has some role to play for poor responder. Letrozole is not indicated and should not be, they do not recommend it, and any dose higher than 300 is not recommended by them. And in addition to recombinant LH, recombinant FSH also increases the number of the oocyte. And random start, stim, all of this requires still more studies. So that were their recommendation, and they've condemned use of antioxidants and all other things, growth factors and growth hormone and all of it. So now we go ahead and move to the Posadian classification, because that was formed to at least separate the management part for understanding that which women fall into which group and then managing it. So for the Posadian classification, taking group 1 or 2, where it is an unexpected poor response. For the age less than 35 years of age, probably recombinant and stimulation with a recombinant FSH to LH, approximately 2:1 should do good, and then maximum dose that needs to be given to these patients is 300, not more, because it will not do any benefit. For group 2, where the age is higher, in that case, recombinant FSH is the only thing that needs to be given. For younger age, HMG can be preferred over recombinant FSH if the patient is not affording. The reason for low response, either the BMI is high or the drug given is low, or can be genetic polymorphism or asynchronous development. For group 3 and group 4, in these cases, more or less, either that is poor responses because they don't have much response, where the enteral follicle count is less than 5 and AMH less than 1.2 nanogram per ml. In that case, of course, pre-treatment, if required, should be done with the estrogen priming, and stimulation should be done and started with 300 units of rec FSH for both of these patients. And for group 4 patient where the age is more than 35, egg donation is also an option that one needs to give. And in this case, fresh embryo transfer is preferred over frozen embryo transfer. So with a younger age in group 3 particularly, role of antioxidants and CoQ come into play. So these are the women less than 35 years of age with poor response in poor biomarkers should be given the antioxidants. So I'll just rush through this. Poor responders we like to trigger with the double trigger, that is giving agonist as well as HCG for final oocyte maturation. And it has multiple papers which have been published and studied, and it's a preferred way of triggering these patients. Also, dual stimulation can be considered in group 3 and group 4 patients. So these are the management options for the poor response. First is pre-cycle, we either give DHEA or maybe pre-cycle ocipil for programming or estradiol. And either antagonist or agonist, whatever protocol for IVF can be preferred. And in laboratory, ICSI is the method of choice for fertilization. But yes, we also sometimes prefer doing IVF if the eggs look good once they are out. In vitro maturation is something which is still under research, but it is probably will come into practice probably sooner in next 5-7 years. And donor oocyte program is something that, of course, an option for these patients should be given. So poor responders are heterogeneous. Just to summarize, they are heterogeneous group and not a homogeneous group of people, and they should be evaluated more precisely as per Bologna criteria. And their starting dose is 300 IU of FSH, which can be maximum increased to 450, not more than that. And cryoaccumulation of the oocyte of vitrification is also one of the strategy which should be offered. And dual stimulation for particularly for group 3 and group 4 of the Poseidon classification is one of the approach that can be considered. And addition of letrozole to gonadotropin probably is not recommended. But yes, transdermal testosterone and growth hormone increases the chances of the live birth rate. So I thank you all for a very patient hearing.
Thank you, Dr. AZADEH Patel. It was very elaborative talk. There was a technical glitch. Yeah, I think everyone enjoyed your talk. So I would like to invite experts to give their special comments.
But you stop sharing.
Very informative talk, Dr. AZADEH. Here I would just like to share my experience. Initially, we used to use growth hormone, but we didn't see much success or any better results with growth hormone. You said you strongly believe in growth hormone and you are using it for all your patients. I would just like to know what is the dose schedule either you are using in the initial few days, daily, or towards the later half, and how do you say that the results were better? You got good quality eggs or whatever the success was.
Ma'am, I use growth hormone where in case of elderly patients, that is about 36-37 years, where I would expect even poor maturation of the oocyte, whatever they are retrieved.
That means group 2.
Yes, group 2. Yes, group 2. I don't use it for group 3. I don't use it for younger patients. So for group 3 and group 4. Group 2 and group 4.
And group 4. Yes.
For those patients. And the dose that I use is 4 international units of growth hormone throughout the stimulation, starting from the second day with the stimulation till the day of
trigger. Right.
Yes.
Right.
You can use maximum till 20 international units, but I think 4 international units is a good thing along with FSH. What I have seen is definitely improvement of the number of the follicles. So for this, the patient does not wait for 1 or 2 cycles to, add up follicles and there is an immediate. Of course, it is not going to do wonders for them. That even addition of 1 or 2 follicles probably might help them.
Okay, thank you.
G.A.Rama?
Yes, ma'am.
Yes, regarding
Yeah, we also use growth hormone as she had mentioned, and numbers may not increase, but definitely if you see the embryology, the quality of the oocytes may improve. That is the advantage of giving growth hormone. And we also use 4 international units. So we started from the... Madam?
No, I just wanted to know from you, sir, from the beginning till the day of trigger. From the day of stimulation till the day of trigger, 4 international units. Okay, so now that 2 experts are talking about it, we will also start again and see the results.
But ma'am, it should be
Definitely,
used with caution because the adverse effect is something that we don't know much, and we have been using, and I've not seen any adverse effect as of now in last 4-5 years. So
I think the adverse effects are with the much higher dose of maybe 10-12 milligrams, because 2 and 4 milligrams is a very small dose.
yes,
Except
yes,
for increasing the cost, if the quality improves, it helps.
yes, ma'am, definitely.
And it's better to give it in the evening times than in the
Okay.
mornings because the growth hormone as such is produced in the evening in the body.
I was about to ask this question, what time?
Yeah. So if I have to give it,
I
I'll
want
give
to,
it
I want a free and frank opinion, not what is mentioned in the book, not what is mentioned there. If you have a strict criteria, AFC less than 5, AMH less than 1.1, and the FSH in case you've got it done more than 15, what are the chances in your practice that you use donor oocytes? Be very frank.
Ma'am, I just did not understand. For a poor responder with a high FSH, 50 you mentioned or
See, the
50?
criteria for poor responders are if the AFC is less than 5, if the AMH is less than 1.1, or in case if you happen to do FSH, it's more than 15. Now, in such cases, in your own practice, I will share what's mine. The Brigadier Sharma will share his something. Dr. Seema Sehgal will also speak. In your practice, what is the incidence of a donor IVF? I just want to ask that.
Ma'am, I have not done a donor IVF for this kind of particular patient. I would rather kind of give them estrogen priming and try to stimulate, because with an AFC around 4 to 5, probably with an AMH around 1.2, must be a previous cycle leftover cyst or something that would be contributing to FSH. I like to down regulate for one cycle, probably with estrogen priming or OC pills, and then evaluate the FSH. And if still that is very, very high, then
FSH, madam, you also know, we also know we have given it up.
yeah.
So we will let's talk about AMH and AFC. If it is definitely 2-3 cycles we watch and you find this is this, what is in your practice is the chances of a donor IVF? Please, this is what I want to ask.
I would go for self, ma'am, not a donor IVF. Still,
That's a practice in majority of your patients in Ahmedabad.
no, ma'am. I can talk only about myself. I would consider the age. If she is very high, 38, 39, then of course the option for donor egg I would give. If she is willing, I mean, I've just done a cycle and she's pregnant with twins. With the second cycle, she's 36, ongoing 37 years, absolutely refusing donor eggs with an AMH of 0.3. And with the total number of eggs for both the stimulation, what I retrieved were only 4, and all 4 mature eggs. And first cycle she did not form blast. The second cycle she formed 2 beautiful blastocysts, and which I transferred, and she's ongoing twin pregnancy. So that at the age of 37. So yeah.
Brigadier Sharma, let's hear your honest opinion, sir. What people say, I don't get worried about it, but I think I will love to hear what you say, and then I will share ours.
The thing is, madam, we have to discuss with the patient because there are different categories of patients. Some of them, they would say, okay, doctor, I don't have much of money. You give me baby as early as possible. And, that is my requirement. So I don't bother whether you do the donor egg or whether you do with my egg. So under those circumstances, then you may have to do the donor, okay, because that gives a better chance of pregnancy. There is a second group of patients who would say, no, doctor, under all circumstances, I want to have with my own egg. So then also we have to tell the patient the success and other things, and the cost of the treatment will, because injections and all will be more. And if she still wants that, no, it should be done with my own eggs only. So we'll definitely at least one cycle, we'll do it, because that not be only therapeutic, it will be diagnostic also.
Correct.
Because when we take out the oocytes, we may see the quality of oocytes, the quality of embryos. If we find that the quality of the oocyte and the quality of the embryo is good, and there is a possibility of embryo pooling and she can afford it, so that is the patient, I may say, okay, we'll do with your egg only. But if I find that the egg, all having vacuolations and they are having granulations,
is some issue.
and there is a, 3 overnight. So that is the criteria, because many times you also must have seen, the AMH is very low and the patient has conceived spontaneously as well in the waiting period. So we have to keep the patient's desires also into consideration when we are planning, because if we try to push them into the donor insemination, donor egg program, they may think, that possibly doctor wants to earn extra money and that is why he is pushing me into it. So I think we have to see all the pros and cons, cost and the success, discuss with the patient, and whatever suits her. Then we say, okay, you make the decision, then we'll make it the best. This is normally what I tell them. It's not that you cannot conceive with your egg. Yes, chances are less, or donor chances are better. But if whatever decision you will take, finally, then I will try to make that the best. So if you plan to do with your egg, then I will see whatever add-ons I can give it and whether I do embryo pooling or not, depending on the first cycle quality of eggs and all. So all these things have to be considered. It's not plain and simple. Okay, this much AMH and this much antral count, and I will do only donor program and I will send the patient home. Otherwise, sorry, I don't do anything for you.
I think we definitely appreciate your concern about it. That once the patient says that she wants her own eggs, then I feel that the cost is not an issue at all. Seema, what do you have to say?
Ma'am, absolutely, as sir has said. But I just wanted to know, sir, what is the higher age? Like, what is like more than 42, 45, sometimes 45 years old lady, she comes and she insists on getting pregnant with her own eggs. So what do you say in that case? Otherwise, what you are using, we are also doing the same way. It depends on the patient's desire, basically, on which we take the decision. But sometime after 42, she's coming with poor AMH, poor reserves. So what you do, sir?
Now again, see the criteria would be the same only. We'll discuss about the cost. We'll discuss about the outcome, and also now the chances of having Down syndrome as well. And despite all that, if she says, okay, doctor, even if the Down syndrome come, can you check it early? I said, yes, I can check it early. So we can get rid of that Down baby. I said, yes, it is possible to get rid of the baby also. So if she is, adamant with her own egg at that age, so I don't think, because we have to giving her the pros and cons. We just want to do the case, so we'll do at the age of 40. But in the initial 4 or 5 days of stimulation, you will come to know which direction she is going, and you can tell her, we'll see how it is going, and in case you do well, then only we'll proceed further, or we may cancel the cycle in between as well.
Oh yes. I think this is what it works. People like us also in the first cycle, we say, okay, we will do it with your own eggs. And we are transparent. You will be able to see how many eggs your ovary is producing. And she herself will say, yes, it is not producing. She will go herself. So I also tend to agree. We don't discourage her in the first cycle. Your ovary and your response, you will see it yourself. I will come to second question on the PRP. As for the stem cells are concerned and the PRP is concerned, we are the pioneers as far as this particular thing is concerned. But I know it for sure that PRP giving blindly with transvaginal sonography is not possible. Ovaries are already small. If you have to give it, you have to be always laparoscopically. And there is one study only from Pune which says that there has been a live pregnancy. So we can take with a pinch of salt. Otherwise, as far as whosoever I have concerned, I have come to know about it. PRP has not produced a single baby except the Pune study. What do you have to say on this? I feel it is transvaginal sonography से आप ovary में PRP से कुछ डाल नहीं सकते.
Agreed, ma'am. Agreed. Thank you for this information, ma'am. Thank you. Because injecting 2 ml, even I used to wonder that how is that possible that, inject almost 2 ml of the fluid inside the ovary, which is shrunken less than 2 centimeter, or most of it will just reflux and go out. And it will not work.
Fooling your question. That's it.
Yeah,
it has
true,
to be
ma'am.
only laparoscopically. Nothing is possible.
Nothing possible. Agreed, ma'am.
I used to get a lot of patients from Afghanistan and Dubai. कि डॉक्टर साहब आप हमारी बोन मैरो से लेके वो लीव असाइड PRP, they were ready for bone marrow. बोन मैरो से आप हमारे इसमें एग्स को रिजुविनेट कर दो. I said, look, you are here for anti-aging. I will do it for anti-aging. But I have explained to you that my procedure will not be able to generate eggs for you. You are selling, so we are doing it. When I'm doing it only for anti-aging. Whether they will produce eggs or not in you, I will not know. Sure. So those ladies were educated doctors from Afghanistan and Dubai. They said, okay, Dr. Jain, you do it. I have not found, we have done almost 10, 11 cases. We have not found a single person telling to me that she has got pregnant.
Actually, madam, the problem is that when you are injecting the PRP, either you are using a thick needle, the one which we use it for the ovum pickup. So that makes a hole big enough.
डॉक्टर आपके पेशेंट को जो पुअर रिस्पॉन्डर्स है वो ओवरी इतनी छोटी होती है कि ट्रांसवेजाइनल सोनोग्राफी से नहीं
जाती. Just coming to that, like you are doing laparoscopically, either you will be using a normal ovum pickup needle to inject it, or you may use a thinner needle. Earlier we used to have for embryo reduction very thin needles. So either you will use that needle. Now, if we use thick needle, you are making a bigger hole on the surface of the ovary. So whatever you inject, as soon as you remove the needle, the fluid comes out. So how much remains inside the ovary, we don't know. And when we inject with a thin needle, it injures the platelets because the lumen of the needle is so thin, so it will injure the platelets. So that way also it will not work. So that is why I was never convinced of doing PRP therapy, and touch wood, I have never done it. And I don't regret it.
Another thing, she very nicely talked about activating PRP. PRP for any other purpose also, it will be only effective to the tune of 10% unless it is activated. If you have not activated it, it is not going to work. It's not going to work. So that is one thing. I think the many people who are not doing an IVF are listening. I want to know a person who does not have a money for IVF and she's a poor responder, usko kaise madad karoge, Dr. Patel?
Ma'am, I usually counsel about the chances and everything, of course, all done and dusted, and she still doesn't agree. Also, there are multiple papers that have come, even the recent paper for IUI, which had come up, and it has been published in Fertility Sterility, that IUI with an AFC less than 4 has a very poor chances of pregnancy. So you give data, you tell them. It is not that they are not going to conceive. Probably I would rather condemn any treatment for them, only give antioxidants and ask them not to go for ovulation induction, because that they keep on doing it for months together, and probably leave them for natural trial, because it is not that they cannot conceive naturally. Probably they should leave. I would condemn doing anything else apart from IVF, or they should try naturally. That is what I do. I tell them.
Anybody wants to say anything? Dr. Seema, आप क्या करोगे इनको जो IVF को भी नहीं कराना चाहते?
Embryo donor can be suggested to them.
Okay.
What we normally do, if patient is very poor and she is very persistent for getting pregnant, and they are ready for the embryo donors, and in that case, stimulate that you can share the donors and do embryo donor. That is the ideal way, and really 40,000-50,000 they can afford that much.
डॉक्टर मैं आपको बताना चाहती हूँ, आप किसी के एम्ब्रियो उठा के किसी को दे दोगे, ये पॉसिबल
नहीं
गलत है.
ऐसे नहीं करते मैम. We separately stimulate donors for embryo donor, and we take donor sample of semen also.
Okay.
We have a proper donor wala. But yes, in that we
want to say something, Dr. Jyoti Aggarwal? Please. Dr. Jyoti Aggarwal, you want to say something? Sir, as a chief expert, how you have to sum up?
The thing is, poor ovarian reserves, definitely they are a challenging patients to us. And we have to see the ovarian reserve, we have to see their financial reserve, and we have to see their patient's reserve also. So depending upon that, we have to, plan the treatment for them. And, the patients can go for their own egg pooling, one. The second is they can go for at least one cycle so that they would be convinced that, their egg quality is poor because of vacuoles and, granulations and poor. So they may be ready for the egg donation next cycle. Or, the patient cannot afford anything. So we have only two options. Their poor will, we get a lot of labor parties and all who come over here for treatment. So there we can tell them, okay, you try naturally with the, change their, say, food habits and all. Tell them, simple, good nutritious diet which they can afford, like sprout beans and all, whatever they can take it. And secondly, said, maybe the embryo donation would be the answer for them. And, as far as, this androgen things is concerned, I just wanted to add something.
Dr. Jyoti Malik, are you around?
Like we have phytoestrogens, we have phytoandrogens also. So we can tell them to take this phytoandrogens, like this urad ki dal. It is supposed to contain androgens. So these ladies should be advised to take phytoandrogens, which may help them, giving them, because they are not able to even afford the medicine. So at least dal they are eating every day. So instead of moong ki dal or soya ki dal, they can take urad ki dal sabut. So that can also help them. So I think changing their food habits, which they can afford, and also, the personal hygiene, which is also very important in these patients. So some of them may conceive spontaneously if they could not afford anything else.
Yes, I think.
So nice. Seriously.
Dr. Jyoti Malik is around?
Dr. Jyoti Malik had to leave. She had another meeting at 4:30.
Yeah, I think it's a good discussion over, and we are really thankful to Dr. SHARDA ma'am and Dr. Sharma sir, and especially Dr. AZADEH Patel. My sincere thanks to all of you, Dr. Jyoti Aggarwal ma'am, Dr. Jyoti Malik has left, and Dr. Megha. Thank you very much, all of you, and we'll see you soon on 20th next month. And happy Diwali to all of you.
Happy
Thank you
Diwali.
so much, ma'am. Thank you so much, ma'am and sir. And thank you for having me here. Thank you so much, Dr. Seema.
Thank you, Dr. Azad.
Yeah,
Thank you so much.
It was a nice lecture, Dr. Patel.
Thank you, for us.
Thank you so much, sir. Thank you.
Right,
Dr.
class.
अपना कंप्यूटर का कुछ हिसाब करो.
Yes. I will.
Some Apple
Actually,
issue, because I shared it with
Dr.
Apple phone.
Sajjan is not only
They don't need
promoting,
that possibility.
medicine, she's also promoting, the computer savviness. And, so that's a very good thing. Anyway, she has got a lot of feathers on her cap. This is one of that.
Yes.
She'll make you dance, she'll make you sing, she'll make you computer savvy as well.
Definitely.
I must tell you
It's
that
all because of
I visited when your father was alive in your center. And, it was probably 1.5 to 2 years when it had started. That was the time I had visited. So I'm glad that, the daughter has taken over the part of it. Thank you very much.
Yes. Thank you so much, ma'am. Thank you for sharing that information. Thank you.
Thank you very much.
Thank you, everyone. Thank you, Shanta ma'am. Thank you, Sharma sir. Thank you.